Let's talk about menopause. Clinically, menopause is defined as a point in a woman's life when menstrual cycles stop for at least a year. And with that cessation of menstrual cycles comes very specific symptoms like hot flashes and night sweats and migraine headaches and weight gain and mood changes. And it's no secret that replacing estrogen is a way to relieve those symptoms, but it's not so simple. It's more complicated than just giving our patients estrogen. To help us break it all down, I'm joined today by Dr. Cassie Smith, a board-certified endocrinologist and the founder of Modern Endocrine. Dr. Smith specializes in personalized hormone replacement therapy, and she helps her patients achieve balance and wellness. Today, she's going to share how optimizing estrogen can not only relieve the symptoms of menopause, can also improve long-term health and improve longevity. So welcome, Dr. Smith, to the show, and we can't wait to share it with you. Hey, Dr. Smith, welcome back. I say welcome back because I was on your podcast. You weren't actually on mine. So welcome to the podcast here. We're so excited to have you. How are you doing today?
I'm doing good. I'm doing great. I actually just got back from Scottsdale, like your neck of the woods, right?
Oh, good. And now you've cooled off. Returning to Oklahoma as a cool down, I'm assuming, just because we're blazing hot out here. Summer never ends, as you say. It never ends. So, hey, welcome to the show. And again, I'm really excited about today because, again, when I was on your podcast, we kind of mentioned, like, we kind of did a little teaser talking about, hey, I want to have you on the show and let's talk about estrogen and all that stuff. And now here we are. But before we get into all that cool stuff, I want to know, you put me on the hot seat, had me all about my background and all that. So tell us a little bit about you. How'd you get from endocrinology to functional medicine, opening your own clinic? What's the story?
So I basically got here by way of being a patient, like most functional medicine practitioners or, providers. I was doing my medical school and residency in Kansas City. So I grew up in a small town in Missouri, knew I didn't want to, be in this small town, work on a farm, anything like that. I always loved disease process in humans. And I always thought why do people get sick? And I wanted to make them better. So I ended up going to medical school. And then whenever I was in residency, I actually developed Graves' disease, which is a hyperthyroidism. So overactive, when your thyroid's overactive, and it's typically autoimmune related. And so meaning you have a antibody for a disease, and then large amounts of stress can induce this disease process. And so I developed Graves' disease in residency. And I saw some endocrinologists who recommended I have radioactive iodine ablation, which I didn't want to ablate an organ in my body that was very important for a lot of things. So I decided to seek, additional opinions, ultimately ended up on methimazole, thankfully, and then went into remission. And then after I got out of residency, I decided, okay, well, I want to go to fellowship because I want to learn, how I can help people prevent this or help people treat this, because I was still kind of struggling with some thyroid issues. At that point, I become hypothyroid, and I was seeing all these doctors and I was saying, what caused this? How can I make this go away? How can I make this better? And it was just, you can't take this medicine, bye. And I was like, but, that doesn't make sense. Like, are there diets? Are there other things I can do? And even, in the field of endocrinology, people were like, no, there's nothing you can do. Like, these were the cards you were dealt. And I didn't like that answer. I was also doing primary care, and I was realizing that every patient that I was seeing was coming to me, and I was putting them on more medications every time they came to see me, and they were getting sicker, right? So they would come back 3 months later, and I would be like, oh yeah, maybe, Sally Jane's going to be better because I put her on 3 medicines last time for her blood pressure, her cholesterol, and her diabetes. But Sally Jane had gained 10 more pounds, and her blood pressure was still high, and her cholesterol was still high, and her diabetes was worse. And so I was just putting people on all these medications, and it was very frustrating. So I thought, I'm going to go back to fellowship. I'm going to learn everything there is to know about thyroid and diabetes. I'm going to make people better. So I went to fellowship in Oklahoma City, which is how I ended up here at Harold Hamm. It's a research diabetes center. I did all this research on GLP-1 medications and a lot of weight loss medications, diabetes medications. So I did all this research. I was still trying to find answers myself as to how do you make your thyroid better? How do you, prevent Hashimoto's from coming back? How do you prevent Graves from coming back? And unfortunately, I didn't get those answers in fellowship. They didn't teach me anything about it. They just said, well, they're disease processes and you give people medication. So I got out of fellowship and I thought, okay, well, I don't know, we'll try again, right? So I went to work for a hospital and I thought, okay, I went to work for Mercy Hospital and I thought I'm going to give people all these medicines I learned about in fellowship. Maybe I just wasn't doing it right. As a provider, as a primary care, maybe I wasn't doing it right. Maybe there were things I learned in fellowship that would be different. So I started doing the same thing, SGLT2s, GLP-1s, blood pressure medicine, cholesterol medicine, all the things you give people with diabetes. And although their blood sugars got better, they came back and they were gaining weight and they didn't feel well and they were on more medications. And so it was like I felt like I was just stuck, like I wasn't getting anywhere. You know, their numbers might not be better, but the way they were telling me they were feeling was really disheartening, because I've actually always cared about how people feel. And that's not what they teach us in medicine. They teach you, check the box, move on. And so I came to this, I would lay down at night and my heart was just sad, because it was like I wasn't doing what I felt I was put here to do. And so I finally, after 2 years, was like, I'm done. Because as a patient myself, I was tired and I wasn't getting answers, and I was taking my thyroid medicine and just things weren't changing. So I decided on March 1st of 2020, the worst time in the last century to start a private practice, that I was going to start a private practice. And so I did. And when I did it with the full intention and the full heart of, I want to make people feel better. And what I realized when I did it was that what I learned, unfortunately, in 15 years of training through medical school and residency and fellowship and, all the training that I had, was that none of it had worked. So I needed to figure something else out. And so that's kind of how I came into the functional medicine world, right? I've always believed that like our bodies were made to heal themselves. I think that we're made exactly how we're supposed to be made, and that the body is very fascinating, and it can heal itself. It has for thousands of years. And so I really dove into like nutrition and inflammation and root cause disease. And so that's how I ultimately end up in functional medicine. And I've loved it. It's been so different since 2020. My patients actually get better. I actually take people off medications. I can see from their blood tests, their inflammatory markers get better. And hormones play a huge role in this. So this is where it kind of started. Although I went into functional medicine looking for more thyroid answers for myself, what I got was a lot of hormone answers for my patients, because I understood estrogen, I understood testosterone, I understand how all these things play together, cortisol and progesterone and insulin and testosterone. But what I was finding with my patients was that a lot of the symptoms they were having were from estrogen deficiency or from testosterone deficiency. And when you gave them that back within the right quantity, in the right, type, in the right frequency, they felt better. And so hormones had, where I came from, hormones were kind of in training. They teach you, they're bad, they cause cancer, they're terrible. But what I found in the literature and in treating thousands and thousands of women is that if you do it correctly, in the right doses, in the right forms, with the right monitoring, that it actually helps people. And so that's where I am today.
Awesome. And I would actually, counter that. I think opening your practice when you did in 2020 in March, and I opened mine in August, and I had that same hesitancy, like, oh my God, what am I doing? Like, I'm literally opening this practice up and people can't leave the house. But in hindsight, it was great for us and for the patients, because a lot of our patients, if you recall, those new patients, they came because they couldn't go see their doctor. Their doctors basically, like, they got shut out, like, hey, you can't come in, you can't do this, we can't take care of you. And so people were struggling even to get certain refills, especially if it wasn't in that considered essential, right? And so for you and for myself, we provided a safe place for people to be seen and taken care of and make sure their health is still thriving throughout that. So I would say it actually worked out really good for you. So that was actually great. And so, man, but it was a challenge. I was like, all right, how do we do this? How do we stay open? How do we put all these measures in place? And, it was a lot, not to rehash one of the more painful times in history, but, and I'm really glad that, you found your way here, and it seems like you are thriving. Actually, we know you're thriving for the things you're doing. So I'm excited that you're here. Now, today I was thinking about, we were kind of going back a little bit, hey, how are we going to do this? And I was creating my outline. The engineer in me is like, I need it to be so structured and all that. And so I want to talk to you today, and I want to tell the story of estrogen, right? I don't want to just jump in like, here's estrogen, you're menopausal. I want to take estrogen from its life cycle and where it starts, not so much where it starts. We're not going to go puberty. We're not going to go that far back, but we're going to tell the story of estrogen through premenopausal, perimenopausal, postmenopausal, and how this hormone is amazing across that spectrum, but also how it needs to be, I always think about hormones like a playground, right? And then testosterone is like the happy, the fun kid. Testosterone is everyone's buddy, right? It's like a super cool kid. And progesterone is kind of like, hey, we'll help you out, kind of a people pleaser. Estrogen is the kid that is like, hey, I'm nice, but if you look at me the wrong way, I'm gonna smack the shit out you. And that's just really estrogen, right? It's amazing, but it also, if it's out of control or if it gets, we call estrogen dominant and cause all kind of issues. So let's start by discussing estrogen in the premenopausal female. Tell me how that changes throughout the month and how your patients feel as those changes happen.
Yeah, so that's a really good question. So we're going to talk ideally, right? Meaning no other metabolic issues. Mm-hmm. So ideally, no metabolic issues when a woman starts her menstrual cycle. So when she starts bleeding, day 1 of her menstrual cycle, this is what we call the follicular phase, right? And so in the follicular phase, or the front half of your cycle until you drop an egg and ovulate, which is typically around day 14 if you have a 28-day cycle. Everyone's is a little different. But in that first half of your follicular phase, estrogen is dominant. So we have a ton of estrogen. So this is like, women, this is why you feel so good when you bleed. Like you might feel really crummy up to the point of bleeding, but once you start bleeding, you're like, oh, thank God, because you have all this estrogen, and estrogen is just like a powerhouse. Okay. So estrogen will make you have more mental clarity. It makes you feel better. It actually lowers your insulin level. So this is where I couldn't figure out why, if you really look at literature or what you're taught in school, like why do women feel better when their estrogen's high? Because like you said, a lot of times it makes people crazy. So if it gets too high, we feel crazy, right? But why does estrogen make you feel so good? Well, one of the main reasons is because it lowers insulin. So estrogen and insulin are on this nice little pendulum. And when estrogen's really high, it makes your insulin resistance get better. So if you have insulin resistance with PCOS and things like that, when your insulin comes up, when your estrogen comes up in this part of your cycle, your insulin goes down. And when your insulin goes down, you're less hungry, right? You feel better. You have less brain fog. You sleep better. You can put on, this is when you need to be lifting heavy. This is when you can put on some muscle mass, right? You can fast longer. And so it's just like this dominant part of your cycle where you just feel better. You have more energy. You can get stuff done. And so you have this surge of estrogen in the front half of your cycle. Your progesterone's pretty low. Your estrogen's pretty low. And then you have this LH surge around day, depending on your cycle, 10, 11, 12, and then you ovulate on day 14. Okay. So you drop an egg. Well, when you ovulate, that starts kind of switching things in your cycle. So now estrogen starts to fall, progesterone starts to rise. Now, the key to ovulation too, and this is why it's so powerful. If you track your cycles, women, you'll understand this. About 48 hours prior to ovulation, you also get this surge in testosterone. So there's like this 48 to 72 hour window in a woman's cycle where she has really high estrogen. She has really low insulin. She has really high testosterone, and she has low-ish to increasing progesterone. We feel amazing. So those are your days where like you can do anything. I joke that if you put women in that little 48 to 72 hour window right there in the mid cycle, if you put us in a room, we could solve all the world's problems because we have all of our hormones like exactly where they need to be. Our testosterone's high, so our brain's on point. We feel well. Our estrogen's high. But then as we ovulate and our estrogen starts to dip, our progesterone starts to rise. Now that's a good thing because you need progesterone to rise, especially if when you ovulate, you conceive, right? So if you conceive and you become pregnant, you need progesterone to protect that pregnancy. And so this is why it happens in the cycle. But the other thing with progesterone, when it rises, we sleep better and it helps our mood. So that's kind of a good thing as well. But as our progesterone comes up, what I will tell you is that our estrogen goes down, our insulin starts to come up. So this is why in the back half of your cycle, you get all these weird cravings. And that's completely normal, women. So like if you feel like, oh my gosh, I'm tired, I don't want to go to the gym and I want to eat all the pasta and sweet potatoes and chocolate, it's because your progesterone's high. And so and your estrogen has gone down. And estrogen actually helps with satiety and it helps your gut. And so the back half of your cycle is, was evolutionarily to make sure that you could protect a baby if you conceived, or an egg. But the progesterone, when it rises and your estrogen decreases, although progesterone helps your mood and your sleep, sometimes it can make us cranky because when our estrogen's low, we also have symptoms as well. And so your estrogen will be low, your progesterone will be higher in the back half or the luteal phase of your cycle. Now, the other thing that can mess with this is cortisol. So many people have elevated cortisols, right? So cortisol is a stress hormone. When your cortisol is really high, it drives your progesterone down. So this is the problem with most women. So ideally in a cycle, if your cycle and your hormones are cycling correctly, in the back half of your menstrual cycle, you may have some food cravings, but you really shouldn't be in a terrible mood. You shouldn't be having really bad cramps. It shouldn't be like the worst week of your life. If so, we know your hormones are out of balance, because what's supposed to happen rhythmically is when your estrogen goes down, your progesterone comes up, and your progesterone can kind of pad all those bad feelings. It helps you sleep better. It helps your mood until you bleed, and then it transitions back into the high estrogen, right? It's a little harder to fast when your progesterone's high, and we know that. So really, if you're doing a lot of intermittent fasting, women, you shouldn't do a lot of it in the back half of your cycle. You don't want to do things that stress yourself. Not a lot of cold plunging, things like that. But the problem with a lot of women is their stress is really high. And when your stress is high, your progesterone doesn't come up like it's supposed to. And a lot of times your insulin is low. So now you have no insulin, or I'm sorry, you have no estrogen, you have no progesterone. Your testosterone started to come down too. So that week before your menstrual cycle, if you are just miserable and hate your life, it's probably because your hormones aren't cycling like they're supposed to. Your cortisol is really high, so your progesterone didn't come up. So now you have no progesterone, you have no estrogen, you have no testosterone. So welcome to, early menopause, basically.
Oh, it's amazing. And so that's such a good point here, because I think what happens is a lot of doctors, and sometimes when people just get started in hormones or just get started in functional medicine, there's this high alert for estrogen dominance. And you mentioned a key part is because if I look at your labs, say day 8 to 14 or so, if you don't know any better, you say, oh my God, you're estrogen dominant. Oh my God, your estrogen 400, your progesterone 0.3. I got to put you on progesterone. And that's a whole other issue right there. But when you actually do that testing at the right time, and I know I was trained, and we try to do between day 19 and day 22, and this is depending on how the length of the cycle, so it's going to vary. So somewhere around mid-luteal phase is when you want to look for that. And like you said, that's when you should see that rise in progesterone. But this goes into some of those PMS symptoms, right? And so many of those PMS symptoms are because at that point in the cycle, you're right, the progesterone is low and the estrogen's high, the hormones are off balance. And so a lot of times you'll see providers that know better. And again, this goes into traditional medicine is like, okay, let's put you on birth control, or let's do a procedure, when it's like, well, maybe you should have gave her some progesterone. I mean, perhaps, or actually looked at that, or maybe how about some estrogen detox? How about some glutathione? How about some DEM? How about looking at your diet, right? And I think that is a smart part that you brought up, is like knowing when to check the hormones and recognizing when that estrogen is too high and the progesterone is too low. And instead of like and this goes down to treating the whole person, not just like, hey, let me put a Band-Aid on it, but let's see what we can do and get everybody to support itself in that part of the cycle where it needs things the most.
And the other thing you want to look at too is what is their cortisol and their insulin fasting, and what is their DHEA? Because that tells me a lot about how is their adrenal gland working and how insulin resistant are they. If you've got somebody, like I saw this girl the other day, she's 23. Her insulin fasting was 56. Her cortisol was 26, and her DHEA was like undetectable. Okay. Now she was on birth control, so that messes with some stuff. But like, you have to know what's going on with the person. So if their insulin's really high, I'm not shocked if their estrogen's low. And if their cortisol is really high, I'm not shocked if their progesterone's low. And if they're on birth control, I'm not shocked that anything's low, right? But then if you've got someone who's got a high insulin, you've got someone who's got a high cortisol, you've got someone with a low DHEA, their adrenal shot. And so you've got to fix those things, because guess what? Your body is not trying to make hormones. It's not worried about that if it thinks you're dying, right? So if you've got a really high insulin, you've got a high cortisol, your body's stressed out. It's like been running from a lion for months. And it's like, I don't have time to make sex hormones because I'm just trying to make sure that your blood is flowing to your heart and your brain. And, and so you have to look at the whole person. And you're right. If you don't know what you're doing, people look at these people like this girl had been told, well, maybe you're, in menopause. I'm like, you're not in menopause. You just have a lot of metabolic derangements that we need to fix, right? Because your adrenal and your ovary as a woman are what responsible for making your hormones. And both of them are shot right now. And your estrogen or your insulin's really high. So you have to kind of understand all those things for sure. And so anytime you're checking hormones, I mean, in our clinic, we do a lot of lab testing, but we always check cortisol and insulin, especially in a female, because they're so tied to, estrogen and progesterone. It's so important. And I don't think it's fair to give a woman a diagnosis or give her any information about her hormones unless you at least look at those things. I would go far enough to say you also need to look at their gut and look at their metabolic detox pathways, because a lot of people are getting estrogen stuck in their gut, recirculating estrogen, things like that. And that's really important too, and causes a lot of terrible symptoms.
Exactly. And I just wonder how many, mentioned like that, not looking at the whole picture. I wonder how many women are on antidepressants and anti-anxiety medications, where it's like, you probably should have, that physician, hey, look at the hormones, look at the cortisol, look at the adrenals, because again, it's like, it looks, if you don't know any better, it looks like that. It's like, oh, wait, you're just depressed, or you're having mood swings. It's like, no, it's a hormone imbalance, right? And so I think that's super important, all the things that you talked about. So let's go a little further down. So now we're going to take estrogen a little bit further down its story and talk about perimenopause. Now, you mentioned that early first half of the cycle in the follicular phase, that estrogen rise and that decrease in the second half. How does that change when women get into perimenopause?
Yeah, it gets, it's kind of like a roller coaster, like a circus act, unfortunately. And everyone's different. So the frustrating thing about menopause and perimenopause, this, women come to me and they say, well, my mom went through menopause at 50. When am I going to go through menopause? We don't know, and if you get in this perimenopausal phase, you can be in it for 5 or 10 years. And so that's the other frustrating thing too, because people don't feel well. So it's kind of like, what happens is, when you bleed, you start bleeding, your brain is supposed to release something called FSH, which is it's a hormone that stimulates your ovaries to make estrogen. And so your brain starts to get kind of lazy, I guess, as we get older, we could say, right? And so maybe it's releasing it, or it's not releasing as much as it did, or it's releasing it, but your ovaries are lazy. So either way, there's an issue with the signal. Either we're releasing and our ovary just can't make, or we're not releasing enough. And that will depend on some things as well. Some people have secondary hypogonadism from chronic inflammation, things like that. But either way, you're not getting, the signal is not, either there's not enough signal that's going to your ovary, or your ovary just can't make estrogen from the signal. So then what happens is your body's expecting all this estrogen, but it's not made, right? So it's like, hello, where's my estrogen? Because I felt bad and now I want my estrogen, And so it's not being made. And so you may go in 5, 6, 7 days into bleeding and you have no estrogen. So then you start having bad symptoms. Your mood is terrible. You want to bite everyone's head off. You start getting hot flashes. You want to eat everything in the world. You're hungry. You feel like you start gaining weight. You just get all these symptoms and you're just miserable. And then all of a sudden, and this is the frustrating thing, you'll get that signal that's high enough, or you'll make enough estrogen, and then you may get this release of estrogen, but it's this massive release of estrogen because it's almost like this buildup, right? So then it's like, boom, all this estrogen. Well, then that's not fun either. So it's literally like this circus act where we're just, going back and forth of, we have no estrogen, we have symptoms of lack of estrogen, and then we get estrogen released. Now, it's not always that significant, but that's kind of the game of tug of war that's going on when you become perimenopausal. And your body just gets uncomfortable with that, because it's like, okay, for years I've had this cyclic, this pattern that I'm used to, and now I don't have it. And so that's kind of what happens as we start getting closer into menopause, is like that signal's being drop. And then when it's finally strong enough, our ovaries are releasing some estrogen, and it may be a normal amount, it may be a lower amount than normal, or it may be too much. And most of the time it's either too much or too little. And so we have some symptoms. And then as we get, so then we go through the middle of our cycle, we ovulate if we're ovulating, and then we get into the back half, or the luteal phase. So now we've got this issue where we're not making enough progesterone either, because we're kind of getting to the end of our cycle. So now that we've had all these miserable symptoms in the front half of our cycle, we want to eat everything, we're hot, we're really cranky. Now is supposed to be the time where we get all this progesterone so we can actually sleep and recover and rest, and our mood gets better. And then we don't have that either, unfortunately. And, it's kind of this big, people who say like, well, menopause is just a thing. It just happens. It's just with age. You should just, embrace it. Well, let me tell you physiologically what's going on in your body when that tug of war is happening. When that tug of war is happening in the beginning of your cycle, your cortisol, which is your stress hormone, is through the roof, right? It's like, oh my gosh, what's going on? Well, then that makes the progesterone in the back half of your cycle even worse. So remember I told you when your when your cortisol is high, you're not going to make progesterone because they teeter-totter just like insulin and estrogen. So it just makes this back half of your cycle worse because your body was stressed. You're not making enough progesterone. So now we're not sleeping well, which is so important. We're having more mood issues, more mood instability. So then, we feel terrible at the end of our cycle. So then we go see a doctor and we're like, dude, something's going on. I have like maybe 5 good days out of the month. I don't feel well. And they give you an SSRI because they're like, oh, you're nuts. Well, you're not nuts. You just need some progesterone. We just need to calm the cortisol down. We need to get you some progesterone, or we need to help transition you into menopause better. Right.
Right. And then on top of that, your testosterone's gone. So now you add in this perimenopause cycle, now you add the fact you don't have a libido on top of that, all that. And it's just without having a good doctor kind of guide you through it and know when you need things and how you need things, it can be a struggle. And again, this is when a lot of it's like, oh, well, you need SSRIs, you need this, or it's just like, oh, there's nothing wrong with you and you're just struggling. And again, this is about advocating for yourself. It's like, if you feel that way and you don't feel heard, this is when you find a doctor like yourself. This is when you find a Dr. Smith, right? To get you in the right place.
Yeah. And testosterone is so important too. It's actually testosterone is women's female dominant hormone. It's just that we have, less of it, and estrogen is so dominant, but women have a lot of testosterone. We have a ton of testosterone, and it is very important for our mood, for our muscle mass, for our sleep. Oh my gosh, progesterone is great for your sleep, but so is testosterone. And then, your energy, like if you don't have the energy to do anything, you're going to feel depressed and feel icky. And so testosterone is really important for that. And that's a good point, and testosterone in women is made in our ovary, but a lot of it is made in our adrenal gland, especially as we get older. And the problem is everyone's adrenal glands are shot because everyone's stressed out all the time. And so it's very important. And it all is this nice rhythmic, they all play together. And so you have to make sure they're all balanced. If not, you don't feel well.
Not at all. Not at all. And now on our journey of estrogen, now you've gone, we started off, things are great, you're young, you're happy. Now you're in that middle part, the perimenopause, and now the transition has happened. And now first the testosterone goes packing, and now the estrogen's packing their bags, and it's like, hey, I'm out. It's been a good run. We're out of here. And so, clinically, when we define menopause, the same thing they teach us in medical school, let's say, absence of a cycle for 12 months. And then you get a little smarter. You realize, yes, there are certain numbers above where your FSH and your LH, your luteinizing hormone, what you can call it that. But again, can't go off of that, because you go off of that, it's like, oh, you're in menopause, and then bam, now you have a cycle and we're starting all over, right? But that being said, there are certain symptoms that can be present in perimenopause, but also that when women do get into menopause, is a certain kind of, and again, to say this, to caveat this, not every woman is going to experience all the symptoms, but when it comes down to it, there are some very, very common symptoms of menopause. And so, Dr. Smith, what are those?
Yeah. So menopause is I joke, it's sort of like thyroid disease, right? It's kind of like almost all encompassing, but I would say the thing that I see the most is hot flashes or just heat intolerance, right? Women will say, they don't necessarily say I lay down and I soak the bed, although a lot of them do, but they will say like, I'll just be in a room and I immediately start sweating. It's really embarrassing, So temperature regulation issues is one of them. The other one is dry skin. Dry, just in general dry. So it can be skin, it can be your mouth, it can be your eyes. I have women who come to me and they've seen multiple eye doctors and they're on all these eye drops and they're like, have scratches on their cornea, and their doctors are like, I can't figure it out, and giving them eye drops. And I'm like, well, I start talking to them about menopause. Well, guess what? Their vaginas are dry too. So that's another issue. So if you're having vaginal dryness, if you're having yeast or urinary tract infections, if you're having pain with intercourse, any sort of dryness, if you're starting to have dental caries that you've never had, so cavities, that can be from menopause. And I see that's overlooked all the time, right? Eczema type symptoms on their skin, but they're also having issues with their teeth. And they're also saying, I have all these. I see a ton of women who have urinary tract infections, haven't had one in 10 years. Now I've had 6 in the last year. I'm like, okay, well, are you having vaginal dryness? Yes. Does it hurt when you have intercourse? Yes. Is your skin dry? Yes. These people are in menopause. Like that is menopause. So dry, issues with sleep. That's another thing. So when you cannot sleep, you wake up at 2 or 3 o'clock in the morning, and it's not like you're necessarily anxious. You're not really thinking about anything. You're not even necessarily hot. You just can't sleep. That's another one. The other one that I find that's really common is women will tell you, I haven't changed anything, and they really haven't, but they get this little tube around their tummy, right? So they get what we like to call a muffin top. That's because they start, like, their insulin starts to change and their testosterone levels start to change. So those are some of the symptoms as well. And then mood instability. So it does really affect not only blood flow to your brain, but it affects the, norepinephrine, serotonin, tryptophan, things like that, because of the way that you absorb things in your gut. Because estrogen is actually really good for your microbiome. And I think this is something that a lot of practitioners miss, is how important our hormones are for the microbiome of our gut. And what we're eating in this country is a travesty to begin with. But then when you start messing with the actual microbiome and the flora of a gut, and you start developing leaky gut, which is really common when you're going through hormone issues, then you can't absorb these micronutrients from your gut. Then we've got a big problem there as well. And then just so mood instability, heat issues, dryness, whether it be your skin, eyes, vaginal dryness. Some people start to break bones, which that's kind of way down the line. But those are, I would say, kind of the main things people will tell you about is women will say, I feel like I want to kill my kids. I want to kill my husband. Everything they do just makes me want to, and then they're starting to get weight gain around their abdomen. They're having issues sleeping, dry skin, and heat intolerance.
Sounds like the Seven Dwarfs. And then that's one of that old, it's like, I'm grumpy, sleepy, like all that good stuff.
Is there a seven dwarf that's bitchy?
It's the eighth dwarf. It's the eighth dwarf. So one didn't make the cut. Didn't make the movie. The kids couldn't handle it. All right. So again, we often hear about estrogen because that's the thing, like BHRT, and even the most basic doctor is going to say you're in menopause, let's put you on some estrogen, right? I mean, even that's kind of a more standard approach here. But that being said, we often hear about estrogen in this context of relieving symptoms. But what are some of the other benefits of estrogen when it comes to longevity and overall health and wellness?
Yeah. So this is where I think we also miss the boat. We scare women into you shouldn't take estrogen because it can cause cancer, which has also been debunked and is crazy, assuming that you're taking a reasonable dose and it's being monitored. But estrogen is so important. So we can just start at the top and go down. So it's so good for your brain, right? So it helps with blood flow to the brain. So estrogen and testosterone both help decrease your risk of dementia. So if you have very low estrogen and very low testosterone, then you're going to have less blood flow to the brain. And it's also been shown that these hormones can help decrease beta amyloid plaque in your brain, which is what causes dementia, right? So it helps with blood flow to your brain. We talked about all the secretions, your eyes, your mouth. So like, who wants to have super dry eyes? Who wants to have cavities? No one. The other thing is your heart. Oh my goodness. So women, heart disease is still the number one killer of us by far. It kills more women than the number 2 through 16 causes combined. We still die of heart disease so much. And almost 2/3 of women that die of heart disease never had a symptom prior, which is terrifying, right? And then most doctors don't check lipoprotein little a, so they don't even know that you're at risk. Most doctors don't do coronary calcium scores, so they have no idea you're at risk. They're just checking your LDL, which is a terrible way to know whether you're at cardiovascular risk or not, right? So it helps with heart disease. It helps decrease your risk of cardiovascular death, because what estrogen does is it prevents plaque buildup in blood vessels. And that's why women, when we get heart disease, it's nasty. Like if you ask a cardiologist, when they cath a woman, they will tell you that if a woman has heart disease, it's diffuse and it's everywhere. It's in every vessel. It's all spread out. It's just a mess. Like they can't put a stent in it. When men get heart disease, it's like one little place in a vessel. They can go in and kind of either rotor-rooter it or make a little bypass. When women get heart disease, it's not like that. It is everywhere and it's diffuse, and it's because we lose estrogen, and estrogen is what protects our hearts. And so to me, first of all, everyone has a brain and you need your brain to function, right? So I don't want to have dementia. And then you need a heart. So these are two pretty solid reasons why estrogen is very important, just for your, physiologically. Now, if we're talking about livelihood, also estrogen, again, it helps your skin. It helps your vaginal health. It helps with you being able to have sexual intercourse with your husband and enjoy it and not be painful, which is a very important part of life. It also helps with bone health. Okay. So your bones, we know that when you go through menopause and you lose estrogen, you lose 25% of your bone mass and about 3 to 5 years after you go through menopause, which is crazy. 25% of your bone mass is lost when you lose estrogen. And it's so important because a lot of women don't have good bone mass to begin with, right? Because we weren't eating our calcium and vitamin D in our 20s, and we weren't doing weight bearing exercise, and we've been stressed, and we're not getting our vitamin D like we're supposed to. So it is so important for our bones. And then our mood, like we talked about this, estrogen, testosterone, progesterone is so important for our mood as well. Just keeping you mentally where you need to be. And then if you have enough estrogen, it's going to help lower your insulin level. Who doesn't want that? Like, who wants to walk around with high insulin levels, right? High insulin levels make you gain weight. They make you have brain fog. And so those are just some of the reasons right there. I think from a longevity standpoint, Dr. Jones, the best thing about estrogen is it lowers inflammation by lowering insulin, right? So we know that inflammation is the root of all cause evil. Inflammation is what causes disease and what causes ultimately death and aging. Well, the best way to lower disease, aging, and death is to lower inflammation. And insulin is one of the most inflammatory things in our body. So why would you not want to take something that gives you all the things I just talked about, plus lowers inflammation? And it's something that you had naturally your whole life anyways. So it's complete craziness to say, to people like, if you take this, it's going to increase your risk of cancer. It's going to increase. No, it's not. If it's done correctly, you've had estrogen your entire life. And when you're pregnant, you have estrogen in astronomical levels. And I mean, how many people do you hear of that are pregnant that develop breast cancer or develop, something terrible like that? That's not the case. And so it's so frustrating because there's so many great benefits of estrogen. And if you want to transition through life well, and continue to live your life, then estrogen is a huge part of that. And even in perimenopause, I would say, this, if there are women out there listening to this who are struggling going through perimenopause, you don't have to wait till your FSH is above 23. You don't have to wait until your estrogen's undetectable. You don't have to wait until you haven't had a period for 12 months. You have to find a provider who understands how to look at you as a whole and understands labs and can help you transition through that period because you don't have to be miserable. It's not fair.
No, not at all. And I'll tell you what, man, and the things you just said are amazing. And there's even more. So I've been doing especially because again, we talked before we started here. I was like, in the beginning, when I first started getting some hormones, I had this irrational fear of estrogen, right? It's just because again, because we're so worried about estrogen being high, because again, when estrogen is too excessive and if it goes overboard, then that can drive endometriosis and fibroids and uterine cancer. They're like, oh my God, you get this fear of it. And so, but the more we research, the more we learn about estrogen, we realize besides all these amazing things you just said with brain health and heart health, you also realize that estrogen literally increases longevity genes and that it decreases oxidative stress. And so again, longevity is like my jam. And I think about these hallmarks of aging, and oxidative stress is a huge hallmark of aging because oxidative stress, like you said, drives inflammation, and inflammation drives all the aging processes. And you mentioned cancer. Amazingly enough, there are studies that came out about 3 years ago that shows that postmenopausal women have a reduction in P53. And P53 is one of your body's most potent anti-cancer molecules. And so with estrogen replacement therapy or BHRT, they saw an increase in P53 and P21, which P53 works on in these anti-cancer scenarios. And then on top of that, I went down this rabbit hole, man. I was going to town. And then there's some other studies that come out that talk about TRF with TRF2, which is like a telomere releasing factor 2. They're these long names, right? So it's actually telomere repeat binding factor 2. And it showed that estrogen upregulated that. So now we're talking about estrogen or estradiol helping with telomere lengthening and protecting telomeres. So it gets even deeper than that. And then again, the other thing you kind of mentioned the first half of the cycle. Sorry, you said longevity. I was like, did someone say longevity? And then it's like you just put a quarter in me and now I'm just going. And then on top of that, with estrogen and maintaining muscle and increasing strength in postmenopausal women too. And you said something else that I was like, wait a minute, there is a reason why, premenopausal women, they have a lower risk of heart disease when they have all that estrogen. And so now you get postmenopausal, that dips. And like you said, now that flips, right? And just because, again, I got to say one quick thing too. I got to say a little something for the guys here too. At this point, I don't know if any guys are listening. They were like, they're talking about estrogen. I'm out of here, right? But again, for us guys, this is why when a guy's on testosterone, it's just like, look, sometimes you got to back off that estrogen blocker. You got to back off the anastrozole. I cannot bottom out your estrogen because you still need that estrogen for all those same reasons. To protect your heart, protect your bones, protect your brain. So it's super important, Dr. Smith.
Yeah. And so actually, I forgot to tell you too. So estrogen's been shown to actually lower lipoprotein A, which is good, right? And will help with cholesterol. It helps with insulin. And then the other thing is for longevity. I mean, this isn't longevity, but for the women that are listening, I mean, we all are vain humans. If you want to look like you're not a wrinkly bag as you get older, estrogen is what you need because it's what helps your skin stay, it helps with the laxity of your skin. It helps with collagen production. Men too. I know there's some vain men out there, but I mean, estrogen is going to help your skin. And like you said, there's tons of studies that show in men that if your estrogen is too high or too low, like you said, it does increase your risk of dementia, of heart disease. It actually increases your risk of weight gain. And so all those things are very, very important. And, I would also argue when people try to argue with me about cancer and estrogen, let's just talk about this. What are the two highest risk factors for cancer? Age, weight. So we know that the heavier you are and the older you are, the more likely you are to get cancer. Well, guess what? Estrogen lowers your insulin. Estrogen and testosterone help you maintain a healthy body weight. So I'm taking that over that hypothetical risk of cancer all day long, right?
All day, every day. So now you get to this point. So now we know, you go through premenopausal, perimenopausal, then postmenopausal, and the estrogen again lowers, and now you run through all these symptoms. Now you get to this point as a patient, female patient, like, all right, now where do we take it from here? So let's talk about the different ways to replace estrogen or optimize estrogen. And let's talk about, in your opinion, some of the pros and cons of those different modalities or different treatment options.
Yeah, so I would say most women who come to me, unfortunately, come to me on oral estrogen, and it's just not my favorite. Like, would I rather you be on oral than nothing? Yes. But my problem with oral estrogen is it has to be metabolized through the liver. And everyone's liver is like, we have so much stuff being metabolized through our liver. Our liver is the main role of our liver is to detoxify, right? And so most people's liver is just on high alert. This is why fatty liver disease is on an uptick in this country, because we have too much insulin, too much glucose, things that are going on in our liver, and our liver's just like, so to give your body something that has to go through your liver, first pass metabolism through the liver is just, it's not my favorite. I will also tell you that when it metabolizes, it sometimes makes different metabolites that maybe aren't as good. So it's not my favorite. Oral estrogen is not. It is cheap. That's why a lot of people are on it. Your insurance will cover it, right? Your insurance will cover lots of things that aren't good for you, but it's cheap. It also increases your sex hormone binding globulin if you take oral estrogen, which will lower your testosterone. So then if you're trying to fix your testosterone, sometimes you get into these pickles. A lot of new people that are doing hormones don't understand this. So let's say somebody has oral estrogen, you're trying to give them testosterone. You have to keep dumping the testosterone in and dumping it in and dumping it in. And then sometimes you end up with bad side effects because you have this high sex hormone binding globulin, which is binding up some of your testosterone. So oral estrogen is an option. Again, better than nothing, but not my favorite. A lot of people do patches, and I'm okay with patches if you can keep the patches on. So a lot of people have an issue. You change them typically twice a week. And a lot of times what you'll find is it's just hard to keep them on from sweat, from showers, from things like that. The Menopause Society recommends patches. That's their, they stamp on that. I will tell you, I don't have a lot of luck with patches. And I personally prefer when people do bioidentical compounded hormones. So I do a lot of bioidentical compounded estrogen creams. They're actually usually made out of yams or, something to that nature. And so the ring is very, very similar to the actual estrogen ring in your body. You can ask pharmacists to make them, without any fillers, dyes, things like that. But estrogen creams are another option. They typically come in something that looks like a deodorant, something that like deodorant. You just kind of click it and you rub it on your inner thigh, somewhere like that after you get out of the shower. So that's an option. Some women do estrogen injections. And again, not my favorite because we're talking about liver issues. We're talking about dosing issues are a little more difficult, but that's an option. And then pellets. Bioidentical estrogen pellets are another way that people do estrogen. And I use a lot of those as well. I think the plus to those, if you're somebody who, because here's the deal, if you're somebody who is not good at remembering things, so you don't remember to change your patch twice a week, you're not going to put on your cream every day. If you're somebody who's just scatterbrained, you need your estrogen. And so I think that's where pellets come in and are a really good option. I also think that the bioavailability of pellets can be really good if you're doing them correctly. So that's another option.
For the pellets, you got to be good at the dosing. That's the thing,
Yeah, the
this is
dosing.
why I just
It's
can't
the
go
dosing
anywhere.
and the frequency, and you have to know how to monitor the lab. So, a lot of pellet companies will just tell you do pellets every 3 months you have to use your brain. You have to know that estrogen takes longer to metabolize than testosterone. You have to understand how to read labs, follow FSH levels, follow estradiol levels, and follow symptoms too. That's the other thing. When you're treating somebody with hormone deficiency, and you know this, I get labs, but labs are not the say all be all, right? Like you've got to talk to them about symptoms. You have to make sure that you're not going to harm them, but you've got to understand side effect profiles too.
Exactly. And so in our clinic here, we do a lot of the different modalities. Now, there's just some cases where, again, it's going to depend on the patient and what their tolerance is and how they respond. Because again, I've had some patients where like the patches usually starts off good, but eventually it's like I got this gummy ring and the patch is falling off, and I just stopped applying it because I got tired of it, right? And so you have to deal with that. Creams, again, very convenient, and I do agree with you there. But again, it's just the little things with the creams, like making sure you wash your hands very thoroughly, and again, making sure your skin is clean. Don't just go to the gym and try to put this cream on because now it's an absorption issue, right? So you want to make sure you're not spreading it. You want to make sure you're absorbing it, and with the oral, now we do some biased troches. I will do that. But again, it goes down to that education of like, look, you need to make sure this dissolves completely in the buccal mucosa, because again, if you just swallow this troche, now you're going to that first pass metabolism. Now that's when you're talking about the clotting issues and the increase in sex hormone binding globulin, right? And so there's that education piece there. Injections, I do have some patients, they love the convenience of it, but it's just injections, man. I mean, it's just that it is that breakthrough bleeding with injections is real.
Yeah.
And man, look, Cassie, I've tried it. I'm like, you know what? Let's just do 1 milligram every 2 weeks. I was like, what? You're spotting? Like, how's this impossible? Right. And then you realize, okay, you know what? And again, this is not all cases. I have some women that do great on the injections. They have zero issues. It's their jam. They love it. But if we start seeing that, we're going to pivot and say, okay, let's look at a topical. Let's look at the troche. And, again, the gold standard for me, again, is doing pellets. That's just, it's the convenience of it. The levels are more stable. Once you dose it right, you got it. But I feel like it's got to be the right fit for that right patient. But again, and safety is number one.
Yeah.
With the pellets, because once it's in, it's in.
And so you have to be good as a provider too. But I mean, I would say that my go-to are pellets as well. I like creams. Troches are fine as long as I just don't like the oral pills. I agree with you on the patches. And then, the shots, I tried that game too. You want to talk about some bleeding and just the problem with shots, I think is, again, anytime you put something in a muscle, it's setting there or even in a subcutaneous space and it's absorbing, you have to take the patient into consideration. So if you've got somebody who's highly inflamed, who's got a million issues, who's got gut issues, they're not going to absorb that shot very well because it's going to have erratic absorption, right? I mean, and then when it does absorb, it's got to actually cross into the cell it needs to actually go into to function. And their cell membranes are all inflamed because they're inflamed. And so then you're going to get this weird, erratic, nutty response. And estrogen, you got to be careful with because, again, not to say that it makes people crazy, but it makes people edgy, and so you don't want to be giving somebody something that makes them not feel well. And so it is, estrogen's hard, but there are some great options. As long as you're working with a provider, then you can get some great results. And I've gotten great results on most of the things, but I would say I use more pellets and creams than I do anything else.
All right. Now, I know this talk has been all about estrogen, but we will not get out of here without talking about the stepsister. We're treating her like a bald-headed stepchild, and that's progesterone.
Okay.
And so again, and I don't see it very often, but occasionally you will get that patient that comes in and it's like, hey, I went to Dr. XYZ. They put me on a troche or they put me on a patch. And you're like, okay, so what's your progesterone dose? And they'll be like, and they will look at you like, what progesterone? So that being said, tell us, what is the importance? Why is that so important to make sure you're also optimizing or replacing progesterone when you're replacing estrogen or estradiol?
Well, several reasons. Number one, if you have a uterus and you're not on progesterone with estrogen, that is malpractice because we know that progesterone protects your uterus. So you can't give somebody unopposed estrogen. If you do, what you're doing is allowing that lining of their uterus to get thicker and to cause bleeding. And we don't want that because that increases your risk of cancer. Okay. So that's one main issue, right? We don't first do no harm, but a lot of women will not be put on progesterone because they don't have a uterus. And so doctors will say, well, you don't need it, which is insane because there is a nice balance that you want to have with estrogen and progesterone. And again, like we said, so progesterone, I tell people it's God's gift to women. It makes us sleep and it makes us calm, like it makes our mood good, right? So I actually take progesterone in the back half of my cycle, and you will have to pry it out of my dead cold hands with my estrogen as I get older and my testosterone. Because it is so good for your mood and it's so good for your sleep. And so you should be on progesterone, and especially when you're in menopause. You need to take them both all the time so that we keep that balance good, because you don't want one above the other, because then you're going to have mood issues. You're going to have, and so it is very important that you take progesterone with your estrogen. And everyone's a little different. Like some people say like, well, what dose should I be on? I typically do 200 milligrams of micronized progesterone, and micronized is the key there. But some people only need 100. It makes people sleepy. I mean, you have to know your patient. You have to talk to them about side effects, symptoms, and then look at their labs. But progesterone it's a fabulous drug. A lot of women don't want to take it. They're scared it's going to cause them to gain weight. I mean, it does not cause weight gain. 100% does not. It lowers cortisol levels, people. We all need our cortisol levels lowered. So I completely agree. Like it is, people that come to me and they're not on progesterone, sometimes it's a struggle to get them to try it. But I've never really had a person tell me, wow, I'm upset that I did that.
No, not at all. You get that rare case. Like I feel there's always gonna be that one person that just doesn't feel good on something that most people feel amazing on. And that's our job as a doctor to identify that and say, hey, why could that be? Is it because your microbiome is a literal shit show and you're just not absorbing it? So maybe we need to work on your gut health. And while working on gut health, maybe we need to give you a progesterone troche so you can actually, do that, get a little buccal mucosa absorption, get the gut going, and then consider going back to the capsules, right? So there's a lot of different scenarios there. But you're exactly right. It's just finding, the whole point of this is working with a doctor that can meet you where you are and meet your needs and do it safely and do it effectively. And that's super, super important.
So one other thing I forgot about progesterone. So women, if you're listening, I knew this, but I didn't know this until it was an issue with myself. And then I felt really stupid. So micronized progesterone that you get from a pharmacy, a lot of times is made with peanut oil. Did you know that? So if you have an allergy to peanuts, or when you take progesterone, you get a headache, if you will have your doctor compound you progesterone, so write a 225 script or 224 or whatever, and write in there to compound without peanut oil, a lot of times those side effects that you have will go away. So I didn't think about that. And I had a few patients who had that issue. And then I had that issue, and I was like, and so then I had a compounded one made, and then I was fine. So FYI.
That. Serving knowledge out there. Yeah. Serving.
There's a lot of people with peanut allergies, that bother them. Just keep that in mind too.
Or even a sensitivity to it, right? So just enough that that's exactly what it's made of. So, all right, Dr. Smith, I'm gonna let you get out of here. And I've held you hostage on this show long enough, so you can get on about your day. So one thing I did notice, just in prepping for our interview, like, hey, let me do a little bit of research on my guest here. It looks like you have expanded your office or opened a new office.
Yeah, no, we opened a new office. So I was in an office with a partner, I guess you would say, after I after I left Mercy Hospital for a couple years. We had planned on building an office together, but then we parted ways in 2022. And so then I had ultimately wanted to have an office, but was just in the middle of wrapping some things up. So it's always been my dream to have my own office. So we finally opened it on August 16th of this year. So we have a brand new office.
Congrats.
It's amazing. Yeah, we do a lot of longevity stuff. So it's 0.5 miles from my house, and it makes me so happy because I have a cold plunge, and I have a red light bed, and I have ozone and IV therapy, and I have my sauna here. So I have everything I need for like a perfect morning routine. So I'm So
Oh,
happy.
amazing. Well, congratulations to you. Congratulations. Next time I
Yeah,
find myself in Oklahoma City, I will definitely stop by and see what you got going on there.
for
So that
sure.
being said, tell the listeners, how can we find you? How can we find out more about you and your practice and all the amazing things you have going on?
Yeah, so we are pretty active on social media. So we have Instagram, Facebook, TikTok, and YouTube. So our handle is Modern Endocrine. So at Modern Endocrine _ try to put out some good educational content for you guys. I have a podcast as well that Dr. Jones was on, Back to the Basics. I'm actually working on a bioidentical hormone summit that's going to come out in April of next year. So it's going to be 40 really awesome guests. Hopefully Dr. Jones is going to join me and we're going to talk about all things hormones. So I actually interviewed Dr. Joel Kahn the other day and we talked about estrogen's effects on the heart, and he will blow your mind. He's doing some amazing research, but so you can find us there. And then we have a website. It's just modern-endocrine.com. And you can find out all of our information on there as well.
Oh, awesome. We'll put that in the show notes too. So that'll be in the show notes for everyone out there, so you can find out more about Dr. Smith's clinic, Modern Endocrine, and her amazing podcast, which is available on Spotify and YouTube and Apple and all that stuff too. I'm assuming it's everywhere. It's everywhere you need to be. And be on the lookout.
Yeah, and we're trying to kind of expand, at least for online patients. So we have licenses now in 9 states, which is pretty exciting. So we can see people virtually.
Amazing. Well, congratulations to you guys. So I want to say thank you for spending time with us today and taking us through the journey of estrogen and how amazing it can be for not only symptoms, but also longevity and overall wellness and health. And then, big takeaway is that making sure that you and your provider have that discussion about what estrogen you're taking, when to take it, how to take it. Super important, because again, estrogen is a super cool kid, but don't piss her off. Do not piss her off, right? You're going to have a whole lot of issues, right?
Yeah, that's right.
That's the thing, what I'm saying? Tread lightly, be nice, right? So that being said, we're going to get out of here. This has been another episode of the Dr. Jones Optimization Academy with Dr. Cassie Smith. I am looking forward to you guys' feedback on this episode, and we will see you next time. Peace out.